So let me just start by saying welcome, everybody. I know many of you in this room, but for those of you I don't know, I'm Cara Carter. I'm the Senior Vice President for Programs at the California Healthcare Foundation. Thank you so much for being here today. I think this is a super exciting topic on health AI in California, the role of state policy. So we're going to dive in really shortly, but before we do, I want to name a couple of things up front. So I'm very aware that when many people hear the words artificial intelligence in healthcare, their first instinct is concern. That instinct isn't necessarily wrong. There are very real risks that deserve our attention. But at CHCF, we also see tremendous opportunity here and tremendous promise. AI tools have the potential to address some of the most stubborn challenges that we've been trying to work with for years in healthcare delivery. To name a few, things like streamlining the administrative burdens that pull clinicians away from patients, making it easier for people to navigate an unbelievably complex system and access the care that they need, and helping safety net organizations do more with the limited resources that they have. Our perspective today is going to start from that place of opportunity, while being clear-eyed about the work that it takes to get it right, especially for the communities that we care about the most. So a little about us, for those of you who don't know us. The California Healthcare Foundation is an independent nonprofit philanthropy. We're working to improve the healthcare system so that all Californians can get the care that they need. Our focus is particularly on making sure that the system works for Californians with low incomes and for communities that have traditionally faced the greatest barriers to care. We're headquartered in Oakland, which is where I'm based, but we have an office here in Sacramento and some colleagues that are based in Southern California. So today's briefing, for those of you that are new to these briefings, is part of a regular series that we sponsor for the Sacramento policy community. It's held typically both in person, and then we'll release the video later. These sessions are designed with two objectives in mind. The first is to bring you all timely information on key healthcare issues and trends, and the second is to promote dialogue on solutions to the biggest challenges that face our state. If you're not already on our mailing list, we would love to have you. Please do join us and sign up at chcf.org. So I have an obligation to give a couple of quick housekeeping notes before we dive in. First, this session is being recorded. The recording will be posted on our website next week, and everybody who registered, including everybody who's in the room today, will receive an email with a link. That email will also include today's slide deck and additional resources relating to this briefing, so don't worry too much about trying to write everything down. Second, following the panel discussion, we will have audience Q&A. Microphones will be circulating at that time, so you can pose your questions directly. Now, a brief introduction to today's topic. California has made meaningful progress on health AI policy, with proposed legislation addressing a number of points, including risk management, disclosure and transparency, and combating bias. But as this landscape matures, the details matter more than they ever have. So the rules designed to protect patients shouldn't inadvertently create new barriers to care, particularly for the organizations and communities that stand to benefit the most from these tools. This dilemma is particularly critical for safety net organizations. At CHCF, we work closely with safety net leaders across California. From community health centers to public hospitals to Medi-Cal managed care plans, we hear a consistent message. The potential of AI to reduce administrative burden and stretch limited capacity is real, but so is the risk of being left behind. Safety net organizations often cannot afford the compliance requirements that are designed with better resourced organizations in mind. Without careful attention, well-intentioned policy can create an unintended AI divide, where the tools that are most likely to benefit Californians with low incomes are adopted everywhere except in the organizations that serve them. Artificial intelligence is moving fast. Faster in many cases than both the healthcare delivery system and the policy frameworks that are designed to govern it. For those of you working in the Capitol and across state government, that gap presents a real and pressing challenge. How do you set guardrails for a technology that keeps changing the rules? Our goal today is to give you grounded information and practical examples to help you move forward in ways that protect patients, advance equity, and still leave room for innovation. To start us off, I'm thrilled to introduce Dr. Christina Silcox, the Research Director for Digital Health at the Duke Margolis Institute for Health Policy. Christina develops policy solutions at the intersection of innovation, regulation, and care delivery. She'll share findings from the recent report she authored for CHCF called Health AI Policy in California, Insights for Decision Makers. Please join me in welcoming Dr. Christina Silcox.
Thank you so much for the introduction and for inviting me to be here. So we're going to be talking today about healthcare and AI and the role for state policy in that. Just to give you a little bit of a roadmap to the presentation, we're going to talk a little bit about this project. We're going to give you a very brief overview of federal and state AI policies, and then we're going to dive right into some of the results we got when we were looking at key California policies and laws. And then I'm going to touch on a couple of other considerations you might want to be thinking about around AI, and then wrap up with some key takeaways. So about this project, the goal was really to look at the California bills, to identify the existing California bills, to really identify what were the key concerns that California bills were aiming to address, and then think about what are the trade-offs and potential alternative approaches for lawmakers to consider going forward for those same goals. So let's talk for a moment about where we are right now. The current federal administration is emphasizing the importance of rapid innovation and focusing on reducing barriers and expanding AI use, particularly around federal agencies. At the end of last year, we saw an RFI that came out that was really looking for information about what health policies were kind of most burdensome to the development and deployment of AI for healthcare. And then we also saw a recent proposal that is aiming to roll back some of the transparency and risk management requirements that exist right now. We also saw that there was an executive order that came out in December that was designed to discourage states from enacting laws around AI. We've also seen this appear in Congress. However, Congress is very divided, and with us going into election season, I don't expect to see a lot of movement on this topic. In the states have also been very active on AI. All 50 states, Puerto Rico, the US Virgin Islands, my own Washington, D.C., introduced legislation on AI in 2025. 38 states enacted about 100 laws. Most of them were really focused around the key themes we're going to be talking about today. Very few were health specific. Most of them were more generalizable. So how did we go about this project? We identified 41 California bills proposed through October of 2025 that were either health specific. When we read them, it felt like they were applicable to health AI, or that they were about foundation models and were applicable to some of the clinical tools that we expect to be built, that we know are being built on top of these foundational models. We then narrowed the analysis to 26 bills, and we did that by eliminating any bills that did not progress to a second chamber, and then also any of them that were unrelated to the 4 key themes that we found. And those 4 key themes were around governance and risk management, disclosing the use of AI, transparency, and combating bias. All of these bills were focused on either a developer of AI or a deployer of AI. And so when we talk about developers, those are the people that make the AI. And when we talk about deployers, those are the people that are purchasing, implementing, using the AI, less so if they're a consumer user. And most of the time when we're talking about direct to consumer, then the developer would also be considered the deployer. But certainly within health systems, if the clinician is using the AI and the patient is sort of what the AI is acting upon, they would be considered a deployer as well. So I want to talk quickly about the 4 themes that we found when we looked at these bills. The first was really around governance and risk management. And we saw 9 bills that were focused on this. Generally, what they were doing was requiring risk assessments. Most of those bills did not talk about how to do that or recommend specific methods or frameworks. They kind of just set out that goal that you should do a risk assessment. One bill was a little bit different because it was directed towards state agencies. And so they asked the California Department of Technology to create a framework that could then be used by all the other agencies. So we saw that they see the importance of that. So why didn't we see directions? And why would we want to maybe see something of directions? It's really because there's a lack of established best practices. And that's because this technology is evolving very, very rapidly. And so as policy people, as soon as we start to figure out something, everything changes. And so how do we think about that in terms of lawmaking, in terms of regulation? And what I would really encourage here is to make use of risk management frameworks and encourage the use of risk management frameworks. Those frameworks can be modified much more quickly than laws can, and they can kind of go with keep up with the evolving technology. And by incentivizing frameworks, you also give health systems, particularly, a roadmap for how to be in compliance. And this is particularly important for under-resourced health systems under-resourced health systems who often don't have a lot of AI expertise. And I think that you're taking on a lot of risk when you're not quite sure if you're doing things right. Why do I emphasize using safe harbors to do this? One, because again, you're de-risking those lower resource health systems from implementing some of these new technologies because you're giving them very clear roadmaps, and then you're saying, if you do this, you are protected. But the other nice thing about a safe harbor versus a requirement is AI is changing rapidly. There's enormous numbers of uses. And so how can we think about making sure that we're being flexible for that? We leave that space for companies or deployers to use alternative methods by taking on more risk. We also saw some of these bills talk very specifically about certain risk mitigations. The most common of that were human in the loop. Specific risk mitigations are difficult. We're still understanding how effective they are. Human in the loop particularly, we're quite concerned about something called automation bias, which is when the human who's supposed to be overseeing the machine trusts the machine too much and just starts kind of stamping yes. And we know it happens because FDA actually had to send a letter out to some clinicians a couple years ago, just reminding them that this tool was meant to be used in combination with them. And it's only going to get worse as AI tools get better. If I'm a human in the loop and I'm using an AI tool that's right 999 times, by the time it's wrong on use 1,000, I'm not catching that, right? One of the other things to think about with human in the loop is you are trading off quickness. And so one of the benefits that AI can provide is being able to have things be done much faster or provide more of that service without needing more people. But when you pull that back to needing a person to sign off on everything, it may still take less time, but it's not going to be as instantaneous. And so it's not that I'm saying you should go one way or the other, but I think that those two considerations do need to be balanced for the particular use you're thinking about. All right, the second big thing that we saw was disclosing the use of AI. And this is when you're giving a notification to a user or to the consumer that an AI system is being used by them, or an AI system is using their data to make a decision about them. 13 bills included some type of disclosure requirement. Responsibility was generally on the deployer of the tool. That makes sense. And it was often very limited to specific use cases. And we saw this with mental health chatbots. We saw this for certain automated high-risk decisions. And I think disclosure can be a really important risk mitigation tool. And we can use it for a couple of different purposes. Simply disclosing the use to a consumer particularly helps them set expectations for the information that's going to follow. And it also can help prevent fraud. But there's other potential uses for that disclosure if it's combined with other things. And so we saw some bills that disclosed that the use was AI and then had to give an option to speak to a human. Or they had to disclose they were using AI, and then the consumer had to be given an opt-out. or be able to appeal the decision. The challenges with disclosing AI. It's very easy when it's fully automated. When something was totally created by AI, you can put a label on it, this was totally created by AI. What starts to become problematic is when we have a human in the loop. And let me give you 3 scenarios where an AI tool drafts an initial patient communication, and then it is supposed to be reviewed by a human. So scenario 1 is that human looks at that draft for 2 seconds, makes no edits, hits yes, send. The second scenario is that a human looks at that, reads it over carefully, 5 minutes, makes extensive edits, then hits send. And then the third scenario is the reviewer reads over it, spends a lot of time on it, that same 5-10 minutes, but does not make edits and hits send. It's very hard to think of a way to convey how to phrase what happened there in a way that is informative to the person you want it to be informative to. And so it's just something to think about when you're thinking about this. The other concern that we have around disclosure is just alert fatigue. As AI becomes more and more prevalent, we're going to see more and more alerts. And I think that we've all gotten the kind of the cookie example where it starts to become invisible after a while. Just hit accept or decline cookies all the time. All right, so then next I want to talk about transparency. And I want to differentiate here between transparency and disclosure. So disclosure was telling someone that an AI system was in use. Transparency is actually much more about how that tool was built and how it was tested and how it is supposed to be implemented. 7 bills included some sort of transparency requirement. There were several common elements that we saw, particularly around context for use, summaries around training data, thinking about how to, explaining how they tested it and what the performance measures were. And transparency can really help ensure that AI solutions are trained and tested appropriately because you have to disclose that. And we talk about, you may have heard the term nutrition label, and the idea that somebody can then see how healthy was that AI built and tested. We also hear it called model cards, if you happen to hear that terminology. So I think it's really helpful for facilitating responsible deployment. So it's really a big aid to deployers. The challenges, of course, is that there is a compliance burden there, and it is a real compliance burden. And there's also concerns around trade secrecy disclosure and information misuse. This is a very nuanced, complicated space. And so depending on how you might be transparent about certain things, a competitor might be able to take that information, twist it a little bit, and make you sound pretty bad. And so how do we think about that? Well, I think that the key is first to minimize the information that you're asking to be disclosed to only those elements that have a clear safety purpose. You also might want to consider those trade secrecy implications and potential misuse as you're thinking about those elements. But I think in a lot of cases, you will want those elements. And so one option is to allow that information to be provided confidentially to either a trusted state agency or to a third-party body that then says, yes, that was good, no, that wasn't good. And that's a way you can kind of balance some of those concerns. And we saw Pennsylvania looking at a bill like this. And the last thing I want to talk about within the themes is combating bias, something that is incredibly important, both in AI and in real life. And I say that because when we're thinking about combating bias in healthcare, we need to think about combating AI bias in healthcare. We need to think about the reality on the ground. What infrastructure do we have right now to efficiently test and monitor tools for bias, or care for bias, or outcomes for bias? Those systems do not exist. They should be built. And once they're built, they should be used for more than AI. The other key thing is really thinking about whether you can do this in a stepwise way. And so in the reading deck, you'll see we give an example of a federal HHS, Office for Civil Rights. They put out a rule a couple years ago, proposed a rule out a couple years ago that was around this topic. And they got a lot of feedback. And when they finalized that rule, they had really kind of set out a stepwise function that got to where you wanted, that got to where they wanted to, but gave direction along the way and acknowledged where there were gaps in infrastructure. And I think that that was great. I think that that's a real example for how to think through some of these issues. The other realism that we need to take into account is, what are you comparing the AI to? And I'm going to use an example here. We know that there's an enormous disparity in maternal mortality between white individuals and Black and Indigenous individuals. If I created a tool, I'm not a developer, but let's say I was, and I created a clinical tool that, if in use, would cut that disparity in half. In half. Would the law that you want to write make that tool illegal? It's not perfect. It still works better for white individuals than it does for Black and Indigenous individuals. And again, this is not an obvious answer. When you allow something to go out in that way, you potentially disincentivize working to kind of make that as equal as possible. But that's not always a fast or easy process. And I think sometimes with AI and with software, we think it might be. That's not necessarily true. And in the meantime, people who could be saved are dying, because we already have that disparity. So I just encourage y'all to think really carefully about realism as we are trying to do this very important task of combating bias. And this is now, those were the 4 key themes we really saw in the bills. I do want to talk about just a couple of other things, one of which is balancing innovation and regulation. And we know that regulation is often perceived as a barrier to innovation. But in healthcare, we have to be careful, because regulation can be a barrier, but with healthcare, so can a lack of regulation. And why is this? Well, first of all, a lot of times when we are talking about deregulation, what we are actually talking about is deregulating the developer. And when you deregulate the developer, you are putting a lot of risk on the deployer, who inherently has less expertise in healthcare, I'm sorry, not in healthcare, in AI. And particularly challenging for, again, those low-resourced health systems that may not have access to quite as much AI expertise. But the developers are not off the hook, because in the absence of clear laws, courts are ultimately going to decide where the liability lies. Until we have some answers from courts, we don't know where it's going to go, and that creates business uncertainty, which startup funders do not like. And so you have kind of that disadvantage as well. So when we start thinking about really rapid, unregulated innovation, this can really present deployers with conundrums. They get a lot of options thrown at them. They don't have enough information about those options. They don't have a trusted stamp of approval on which tools will work for them. And so this actually, ironically, may push these deployers, especially, again, those lower health system, lower resource health systems, towards well-established companies, and then not work with the small startups that may have a product that works much better for their population. And why is that? Well, large companies have reputations that, at stake that they need to be concerned about. They have much more experience with cybersecurity and data privacy, kind of those things that we worry about with software outside of the AI use. And deployers are, and they should be, concerned about the viability of small startups. And that's because there's a lot of money involved in choosing a tool, building that tool into your workflows, training your workers, and deploying that tool. And if you can't trust that the developer is going to be there to be maintaining that tool and updating that tool over time, then there's a large chance you're going to have to repeat that entire process. I'm going to very quickly touch on definitions. AI definitions are incredibly unstandardized. Generally, when anybody uses a term around AI, I ask them to define it just to make sure that we both have the same definitions in our head. Clear, consistent definitions are really important to, again, that rapid innovation that we do want and safe, responsible implementation. It also, and why is that? Well, partly because it tells the developers, is my tool subject to this law or not, right? I am going to say California does a good job here. You have very clear, consistent definitions. Your definitions are reused from bill to bill. So kudos. So I'm going to finalize with just some key takeaways that I hope you take from this talk. One is that we really need to set the stage for success. So bills need to give that space to developers and to deployers to use flexible, risk-based approaches to meet any requirements, to meet the goals that you want, as opposed to the methods that you want. Legislation can incentivize best practices by using safe harbor opportunities. And again, that might help with the equitable deployment of AI across health systems. It's also important to reduce confusion and compliance cost. And so again, very important to define and align key terms. California is doing a great job with that. I would really like to recommend that you work with other states and start to come up with harmonized definitions across states. And why is that again? Again, let's talk about the small startups that often have very good products. They do not have large compliance teams. It's very difficult for them to monitor everything across states. And so by being more consistent around definitions, by being ideally, possibly, when you have the same goal in mind, more consistent about the actual law itself, you make it easier for those innovative smart startups to be compliant. And then finally, incentivize innovation in general. And by that, I think you really need to set out clear liability frameworks. And those liability frameworks should really assign accountability to the entity that is best positioned to drive the change, whether that's the developer or the deployer. You need to balance transparency requirements with those competitive concerns, those real competitive concerns. And then finally, I want to just take a moment to say we also should be thinking about prioritizing state investments in ways that would focus on transformative impact. What we see with a lot of AI tools right now is sort of automating the system that we have right now, which has a lot of inefficiencies. I think where we can step back and focus on how we would actually like healthcare to work and start to incentivize steps towards that, steps towards building some of that infrastructure that you might need, steps towards maybe putting together learning communities, again, to help those under-resourced health systems. Where are there spaces where we can invest and create incentives to really create that transformative change, not just sort of the automating inefficiencies change that I, as a policymaker, am very concerned about. And with that, I want to thank my co-author, Maddie Cordell, and I am going to hand things off to Stella.
Hi, everyone. So as Christina shared, I'm Stella Tran, and I'm with the California Healthcare Foundation. I'm a senior program investment officer working on our innovation fund team, where we're focused on technology issues that impact the safety net. And I'm super excited for our panel conversation today, where we get to hear a little bit more about the policy considerations that Christina shared in practice and what's happening on the ground. And so on today's panel, we have Chris Kelch, the CEO of Winters Healthcare, a nonprofit federally qualified health center in Northern California that provides over 3,000 patients with services in primary care, maternal health, behavioral health, and dental. And then we'll have Damika Barr, the Assistant General Counsel for Public Policy at Abridge, a company that aims to improve clinical documentation and is live now at over 150 health systems across the US, and including many safety net organizations here in California. Oh, great. And finally, Adam Dondro from the California Health and Human Services Agency, serving as the director of the Office of Technology and Solutions Integration, where he's responsible for aligning technology deployments across Cal HHS, as well as serves as the agency's chief information officer. Thank you for joining us. So before jumping into your reactions to Christina's presentation, I'd love to set the context for our audience here and share where your perspectives are coming from. And so, Chris and Adam, I'd love to hear what are the core problems that your organizations are trying to solve with AI? And Damika, why do health systems or clinics decide to work with a bridge? And then if you could all maybe briefly touch on what sort of day-to-day management of mitigating the risk of AI looks like in your work. And so I'll start with Adam, hand it to Damika, and then close with Chris. Thank you.
In those administrative burden pieces, we're really trying to look at some of these risk management pieces and say, how do we start to do our training, build up skill sets to where people understand what we're doing, some of the problems we heard about, human in the loop, how do we understand how to address those in these administrative processes before we're doing it on things that impact outcomes of decision making for the public. And working in that space is where we're focused. We're also looking at things like language access, right, that can improve individuals' access and can improve upon the way that we do that now, making it more rapid, making it more simple for the employees, making it more cost-effective for people who need to use it. So that's where we're focused right now. And in terms of risk mitigation, that's actually one of the things we're doing is trying to pick the right use cases that match the maturity level of the organization, the readiness level of our staff. So it's not just, is there a possibility of doing something? It's, are we ready for that? And I think with some of the other questions, I'll talk a little bit more about readiness and what that means for data and training and those pieces.
Thanks, Adam.
Hello, thanks for having me, and I'm happy to represent a bridge today. So, why do health systems choose a bridge? And I think they choose our organization based on scalability and trust. So we're in 250 health systems across the country. Big healthcare systems like the Mayo Clinic and Kaiser Permanente. Smaller healthcare systems choose us because we meet them where they are. We have a partnership model that ensures that we can work with under-resourced IT departments, we can understand diverse patient populations, and maybe security questions and needs that you find in the smaller healthcare systems. We are available to support 55 specialty areas and over 28 languages. So healthcare systems like FQHCs, like Winters and others in the state of California know that they are getting the same EHR integration and support that you would find in larger hospital systems. Oh, and I think the second question is about risk and risk management. So when we think about that, we think about some of the tools that are part of our solution. So we have something that we call linked evidence. Linked evidence means that what you find in your structured clinical note is sourced back to the audio and the transcript. So that will allow the clinician to read that structured clinical note in the EHR and then question it as needed and find out where it is in the transcript or where it is in the audio. And then for our partners, we have a trust center so they can understand our security requirements, that we have de-identified data according to HIPAA standards, that we, so many things, that we, I'm losing it, but it's an ability for the health systems to dig in and to ask questions, whether they're big or large, whether they have the big AI governance programs or they don't. They can find out exactly how we're treating their data. I know what it was. We really want folks to know, as you're thinking about technology companies, that we're not going to sell their data, right? We're not going to retain that PHI longer than it needs to be processed. So that's how we support the smaller and the larger healthcare systems as they build their risk management programs.
I'm just going to give a context of what kind of provider I am and what kind of services so you know what it's like on the ground. We're in western Yolo County. we have an organization of 85 people, okay? So small. We have 2 sites. They have medical, dental, behavioral health, and pharmacy all on site. We are in an Epic as an EHR, and that's what we use. So that's kind of what we see, around 5,000 folks, more or less. So for us, what we were looking for, when you're small, you look at, can we do this in-house? Do we farm this out? Things like that, or based on scale, what you can do and what you can't do. So we look for AI to, how does it help with staff satisfaction, patient satisfaction, our quality indicators, how does it improve care? So that's where we were trying to look at things that would streamline and make us more efficient, because we have one of everybody. We have one quality director, we have one operations person, we have one. So streamlining those kinds of things in terms of AI, internal workflows and administrative workflows, as Adam was alluding to, is really important. The second piece is that if you know anything about primary care, that you know that there are not enough primary care providers anywhere, and that is not going to get better. And so by making yourself a more, how do I want to say it? A better quality of life for providers, where they're not spending all their time documenting and they're not spending all their time filling out forms, is a much nicer place to work. And we want that for the folks that are coming in the door. In terms of recruitment, I'm recruiting against Kaiser. I'm recruiting against Sutter. So having those kinds of efficiency are really important for me. And then risk management-wise, so as a federally qualified health center, we have quality improvement, quality assurance, and risk management plans. We have to submit every year to the feds. We get deemed as federal employees, so our malpractice is protected. So in terms of risk, we have to look at things like that. So when we are looking at products associated with the AI, we have to start with, our first product was a retinopathy scanner and reader for diabetics, type 2 diabetics. And it was because it was federally approved. It was one of the first federally approved AI cameras that we could purchase. That's how we had to do it, because we didn't have the knowledge in-house to do other things. The second thing we're doing in terms of right now is we're using Abridged. We vetted other kind of ambient AI listening tools, and that integrates really well with our EHR, and it's made a huge difference. Our clinicians are super psyched about it, and I can talk more about that.
That's great. Thank you all for sharing. So I'd like to talk a little bit about the early impacts that you're seeing in your AI deployments, positive or negative, and how that's impacting your decision to decide on future AI implementation. So I'll start with Chris and D'Amico on this one. Could you describe like a provider or patient whose life has been impacted by AI and how that story sort of influences what you might deploy next?
I'll go first. So we capture love stories. You can find them on our website, and we share them around internally. And love stories are reports that we receive from clinicians or patients who have experienced our technologies. So one love story that I have in mind is a patient from a county in California where most of the population speaks and chooses to speak in their clinical appointments, not in English. With our solution having the ability to understand over 28 languages, this particular patient was so happy that during the appointment, the provider and the patient could look into each other's eyes and have that conversation that sometimes will go beyond just what you're there for the appointment, but maybe indicate other things that are impacting your health, like social determinants of health, if it's housing security or nutrition. That's going to come up in those conversations. So we have a great love note from a patient using our products, and we have so many love notes from clinicians about how using this solution sometimes gives them peace of mind when maybe a patient's late, that they know that the appointment is going to go smoother and that they will have less what they call pajama time afterwards. And just so many providers are saying it gives them time back in the evenings that they usually spend working on their notes.
I'll go with, I probably have an one, but diabetic retinopathy. So if you're a type 2 diabetic, everybody should have an annual eye exam. If you're in a rural area, we serve the majority of the folks that we serve are low income. They don't necessarily have transportation. And if you ask them, you have to refer out to have a special camera, shoot your eyes. You have to go to an ophthalmology or an optometry appointment. So when retinal eye camera in-house, it doesn't even have to be during their appointment. They can just come in and do it. They come in, it's 7 minutes in a dark room. It shoots automatically, the camera's attached to it, the result is right there. That saves time for the patients. They've been so grateful that they haven't had to drive. They haven't had to worry about a copay at someplace else. We have uninsured folks that we can do that for. So it kind of levels the playing field in terms of what's going on. So it's been great for us.
That's great. And has that inspired you to look at other tools beyond a bridge and this diabetic retinopathy screening?
We would like to. I think some of the challenges were mentioned, by Christina. We're small. I don't even have IT in-house. I farm IT out. So building agents in-house is something we aspire to and we're not going to do for a while. So we have to look at other things that we can do in-house. So what are those things? So some of them are administrative. We use ambient AI for our meetings, for listening, for efficiencies there. We want to look at other tools in terms of billing and coding and other things, but then we start to get into some of the nebulous, ambiguous areas in terms of policy and what we can get out there. So we're excited to do it, and we're kind of stuck a little bit.
Yeah, that makes a ton of sense. And Chris, I really appreciate you sharing that you're looking into AI agents. I feel like some of the conversations I'm hearing are folks saying we're just thinking about ambient scribing, like we're still at that part of our AI journey. But I know that so many more organizations are thinking about what's coming after that. So we have to think about how do we get policy up to speed to be able to respond to that. Super helpful. Thank you. So Adam, would love to hear a similar question for you. What are the early impacts that you're seeing at Cal HHS?
Yeah, I think one of the interesting things, maybe not interesting, it's kind of makes sense, but seeing it in practice, where people take the time to prepare, plan, and train, we're seeing excitement, we're seeing innovation, we're seeing staff get on board with how can I use this, what can I do? And where we see people rush into it because there's an opportunity, we're seeing them struggle. We're seeing staff say, okay, you put it on my computer, I'll figure that out later, right? And it takes those kind of leaders to go in and pull it out, and then they're training as it's already there. And so that upfront work is more important than it has ever been. And in particular in that space is the upfront work on the data. Do you as an organization understand what information is going to be used by whatever tool or model you're putting in place? Because just understanding the conceptual capability of that tool has nothing to do with how it will work for you if you haven't done that upfront work. Not to say the least of the security side and the privacy side if you haven't gone through and make sure you understand that, which is more important than anything. But even if you've done that, just the ability to gain the benefits from that system won't be there if you don't do that upfront work. The one other thing that we've kind of seen is that sharing becomes more important.
So I have a specific question for each one of you, and I'll start with you, Chris. So Christina outlined a few common policy tools to mitigate the risk of AI. So she mentioned the requiring risk management frameworks, disclosure, transparency, and others. And I'm curious, what feels most doable for your health center, and what areas sort of raise concerns for you from an implementation standpoint? Not because it's necessarily bad, but again, from an implementation standpoint, might be challenging.
Yeah, good question. Again, as a small organization, we're part of a consortium. So as a federally qualified health center, we're in a consortium with 6 other counties: Napa, Solano, Sonoma, Contra Costa, Yolo, and Marin counties. And we have a health-centered control network. And I mention that because when we went to ambient AI, when we went to a bridge, we had to have disclosures on our consent forms that folks were using. We had to be, we had to train our providers and what they would say to patients when they were coming in to let them know too. We wanted to make sure we were covered. We don't have a legal team there, so we look to our consortium to help take a look at these bigger picture items in terms of risk management and risk management structures around this to see what we can apply to. So that's kind of where we got our, that's how we move forward. Usually we can't do that internally. And the more onerous the risk structure, the more difficult it is going to be for us to implement. So,
yeah, really helpful. And Adam, a question for you. So California is often thought about as a regular in AI, but I think what you shared is that OTSI is also an AI deployer, running systems that touch millions of lives and providers. And so are there any policy lessons from doing that at scale?
Yeah, a few. I think, for one, back to the data, right? That pre-data work is so critical and important to being able to truly leverage it, where we've seen successful and unsuccessful implementations strictly based on that, not even having to do with the AI capabilities and technology. That we really see that as core. The thing that resonated with me most from Dr. Silcock's presentation, and Thais, I've already forgotten the term that you used for your tool, but in terms of the transparency and citing sources, back to the responsibility of the developer versus the deployer. Building in that transparency to be able to trace back, how did this tool that does things that I as a user don't understand, how did it get there? And giving the tools to people in your organization to be able to do that trace back, like that is the key. Because when you go back, the term that I use is cognitive surrender. They've done studies already. Within a couple of weeks, people will stop doing the review. And it's not just that they say actively, I'm not going to do the review. Literally, their brain changes to say, I agree with this. Not that I'm going to check if I agree with it. They just truly believe that they already agree with it after a couple of weeks of doing those review, and it becomes perfunctory. Having processes and governance built around that transparency where they know, like I teach my daughter, stop using Wikipedia as a source for your paper unless it tells you where it got that information from. You need your AI tool to do that same thing so that the employees, for whatever the task is, can double click, and you can build that in as part of your process to say, yeah, that feels right to me. Oh, yeah, it makes sense. They got the information from there. Or when it doesn't make sense, to go back, pull up the recording, see what it's citing. Did I miss something? Did the system miss something? That, to me, is the key thing that we've learned, is that whether, we'll talk policy, right? Whether that's a requirement on the deployer, whether we each need to take that responsibility in terms of the tools that we select, that's the key to solving that human-in-the-loop problem and being able to have it a meaningful reaction and a meaningful interaction between the tools and the people using them.
And D'Amica, closing with you, what are the policy questions or concerns that you're hearing from your customers?
So those policy questions are the same ones that were mentioned in Christina's presentation, and they are around questions around consent. There are worries that the current regulatory environment for privacy is far behind thinking about this multimodal data that is being used. There's policy concerns around auditability and what does human in the loop mean. They want to understand how does the model think about the data output, so the errors involved. So we say confabulations, folks think of those as hallucinations, and they want to know where are there standards around that. We say that our models have a confabulation of 97% compared to an off-the-shelf like a ChatGPT-4, which is around 82%. But there's currently no standards involved in deploying a model, and where do you set that boundary at for the model?
And to all three of you, are there policy areas or concerns that we haven't touched on in this presentation that is showing up in your work as you're out implementing AI? And I love that you called out human in the loop, but are there other things that are coming up? for you all?
I'll just add one of our principles, not just for AI, just in general for CalHHS, is equity. And so when we think about AI, we're thinking about that too, right? And that's come up in all of our conversations here. And I think one of the ways that we think about that in terms of availability, access, is also about what we use it for. And so one of the tools, like people think about AI and they think broad large language models. I want the whole internet to be able to give me any and all information. And there are use cases where that's needed and that's helpful. But a lot of what we do, particularly in the health space, you can really narrow that down and do it in a way where this is the set of information. Maybe it's just internal to my organization, right, that I'm going to have the model use, right? Or maybe I'm using, published papers. Maybe I've got a particular sector that I'm focused at. And if you can narrow it down, not only do you just inherently reduce risk because you're no longer asking Reddit for their opinion, which I love Reddit. I use Reddit. But you're able to really get to that equity and that bias piece because you're not just looking at the output and what tools do I have to check the output. You're also looking at those inputs. And as we all know, you can't eliminate the bias that is in those inputs, right? We have a long history of bias that's going to be there in the factual information. But to the extent that you can identify and know that that's there in the input, it makes it easier to account for it in the output. And so finding things like that are some of the other tools.
I think I'll add something. Health systems as well as the developers, when we think about the AI use in healthcare, we want it to continue to evolve. So what that means is the information that right now is going into the EHR, we want to have the ability for the AI agents to pull that data back out of the EHR so that it can have more use cases. So we are thinking about interoperability and information blocking as we continue to develop AI solutions in healthcare.
So as Christina framed in her presentation, that regulation and policy is often seen as a barrier to innovation. But I'm curious, do you see opportunities for policy to support implementation in your organizations?
I think in particular to build on kind of the principle of equity, right? And we've talked about that this excessive burden can reduce implementation, can reduce innovation. But we've also talked about ways that it can benefit it. And so talking about the developer versus the deployer, to the extent that we can build responsibility in around transparency and having capabilities that allow the deployer to have the right information needed, we can reduce that burden on deployers, thereby allowing smaller deployers to be able to play in that space, but ensuring that some of those safeguards are there. And so it's a very fine line to walk. But I think there are places, probably not helping my opportunities to get employed by some of the big companies, but there are places where if we require the developers to have those capabilities in the model, then we don't put that onus on small shops, knowing that they need to put it in their contract, knowing that they need to ask for the things, needing to train their staff on how to do it themselves. So I think that's one piece. And I think the other piece, back to transparency, not transparency, but interoperability. I don't know much about IBM. I'm not hawking IBM, but they've got a great commercial right now that somebody's daydreaming about, how do I use AI? You have to buy everything I have, and you have to replace all your systems with my system so it will work with your new AI system, right? Building an interoperability where we get away from that, right? And making sure there's ways that people can use it on their own environments, right? Getting to that ability to tie it into your existing system so you're not ripping and replacing things that smaller teams aren't going to be able to do, to the extent that we have policies that require that sort of ability, that you can't create vendor lock-in. I think that will also boost an ability for a broader segment of the population to be able to benefit.
I think what I'll add, in Christina's presentation, she mentioned states working together. So we've seen some states introduce the idea of regulatory sandboxes, and we've heard federally regulatory sandboxes, and it's one of those things where one term can mean a lot of different things. But in the healthcare space, if a state thinks about a regulatory sandbox so that we can use de-identified data, we can test and refine that data with oversight, then these new solutions can be rolled out to clinics after they've been tested. And right now, we're just seeing a lot of regulatory hurdles that prevent that testing. So you're asking the developers to have their own regulatory sandboxes, and then deployment is to real-world people.
I love that.
I just reflect those. So as a small place, again, interoperability, right? We have to look for a bridge worked beautifully with Epic, right? So that was low-hanging fruit for us. We have to look at products right now that are interoperable. And I don't know if anybody's from Epic here. I don't have anything bad to say, but it is a behemoth, right? Epic is massive, and they are a privately owned company still. They are not publicly owned. And although that there's transparency in theory around some of that, it is, if there's not some policy that allows that interoperability for smaller players, it's going to be really difficult for us to get on board with certain things. We can't keep paying a little more for each kind of iteration of software that comes out that does something else. It's untenable for us.
Chris, I want to offer a couple of other things, and you don't have to comment on it if you don't want to, but some of the things that we also talked about prior to this was around like technical assistance or payment models. Do you want to share anything around there? No worries. I can move on to our next question.
Payment models we are on, there's different payment models would incentivize different things. We are on one of a couple of sites in California that are under alternative payment methodology. We don't get paid per visit. You don't have to come in and see this type of provider to get that done. It's based on quality metrics across the board, and we get paid per member per month, and it allows flexibility and ability to innovate in terms of what we do clinically on the ground. Same holds true for AI if we go in that direction. So I don't think I'll. The other thing that we're very into is building the capacity and stopping burnout from our workforce. All right, that I need folks working, and they love to do it if their administrative burden is not huge, and that was Ambient AI Abridged has just saved that. But we've also piloted a 40-day work week. We're in month 9 of that right now, where folks are working 4 days a week, and as part of getting these AI efficiencies in place allows us to do that. So I've talked about the clinical AIs, but we also use AI for our meeting notes, for other things that are going on that's internal associated with our platform right now, and that helps us get to where we are and kind of reduce burnout and hopefully make it a nice place to work.
Thank you for sharing and being in the hot seat for me. Okay, so before we open to Q&A, I like to end and ask each of you to complete the following sentence. So, the single most important thing that California policymakers could do in the next 12 months to support safe and equitable AI adoption in the safety net is ... So, D'Amico, can I hand this one to you?
Oh, man. I think California policymakers can take a look at standards around some of the key areas that were discussed today. So really trying to hone in on what is auditability, what does that mean? Taking a look at areas like regulatory sandboxes as solutions that will allow for innovation, so that we don't see smaller healthcare systems having the inability to get the advanced AI that you're going to see in larger healthcare systems.
Similar, I think it would be to right-size oversight, right-size regulation to minimize the administrative burden of implementing AI.
Just for me, the more that sits with the vendor ultimately for responsibility of being able to discern these models, and if I ask my providers to do 8 different things before they see the patient, associated with AI regarding bias, regarding equitability, regarding transparency, we're doing this now, then I've killed all that kind of savings and efficiency we get from using something like that. So I don't know what the policy answer is, but that's how I would like to see it come down.
Great, thank you. So I'd like to invite Christina back on stage, and then we will have microphones around the room for Q&A.
I'm a patient myself. I'm a complicated patient. I donated my multi-omic data to Stanford recently. So I've shared the data with a course with students. They're using agentic AI with complicated patients to really look at how we can solve for that. But the AI is pretty off, right? We're on our 10th iteration. The data is not accurate that's in my records. The multi-omic data is more accurate. We have different tests that we're comparing, so the different tests have different data points. And so really what I'm curious about in that sense is, how are you thinking about improving accuracy and actually bringing the patient voice into these systems? And the second part of that was, then with that same data, it's now being used to build models that companies may profit from. And so how are we making sure that patients who are contributing this data using AI models are actually being included in the equity and in the model?
So I am here representing Abridge and Abridge only, and not other developer companies. You know, for Abridge, the data that we collect starts at the point of conversation. So it's not submitting information. We may have the ability to do pre-charting, but the information is starting at the point of conversation. Our ML teams work really hard on model improvements. That's why when we say we're in 55 specialty areas and not 60 is because we want to make sure that we have an understanding of what is the requirements for that particular specialty area. Abridge does not sell your data, so that's if we're working with Winters, where the patients who are part of the conversation with the clinician, they don't have to worry that information is being sold. So that's Abridge. I'm sure there's many other developer companies, and they may have different morals.
Hi, I want to say thank you for this really great discussion. I think it's a very interesting space to see where AI is developing in healthcare. And I want to bring into the conversation HR1, since this is a policy conversation, and ask you all, one, just with these new pressures that are going to be on the healthcare system with HR1, there's going to be a lot more pressure for efficiency and addressing a lot of the administrative burdens that you are all talking about. And AI has been promised as a big solution for a lot of those burdens. So the question for you all, especially the practitioners in the healthcare space, how are you preparing for these pressures and thinking about AI as a potential tool? But more importantly, how are you thinking about protecting the values of really providing patient-centered care in this space where AI could be really changing behaviors and the way that we're really thinking about healthcare?
I can give you a little bit, but I don't know if it's helpful. Again, I talked about our consortium level. With HR1 coming down and already hit some, right? We're seeing some of it. July again, next January in terms of that. I'm seeing products coming out from everybody from our EHR vendors to third-party vendors that are using AI to some degree to, everything from work requirements, processing that, to pinging people, to following their, to keep people enrolled on Medicaid that would just fall off administratively. But again, I can't vet those. So again, it goes, when I look at those, we push up to the consortium level to vet those different products for all of us. So we're trying to look at just keeping people enrolled that should be enrolled. And that's our main focus. So
I think just the one thing I'll add on the HR1 piece is one of the challenges with it is, you heard my emphasis on planning, doing these things right. Like, government is supposed to be a slow-moving ship on purpose, right? There are a lot of people on this ship, and when you turn fast and it tilts, a lot of people get impacted by that. This ship is not turning slowly. And so it makes it hard to identify where can I do those things right in the time that's been given. But a couple of things that have represented are how do I use this as a communication tool to enhance awareness of people, to know what's happening to them, to their loved ones, to the people that I work for, is one space. And the other is really around that data, and that work requirements and some of those things are very interesting beast in that some of them are brand new. Some of them are information that's there, not on the screen we typically used, but they're somewhere. And that is a space that AI is really good at, is pulling things out and bringing them together. And so those are two things I'd say that are on the table, being looked at as potential uses of AI to help support keeping people on the rolls.
What I would add is, I think that there is an enormous amount of potential for AI to start to reduce costs and create efficiencies. But starting AI, implementing AI is not cheap. So you need to have that budget to be able to put it in place before you see the savings. And I think that that can be challenging. Now, this was, there was acknowledgement of this, and this is one of the reasons why they put together the Rural Transformation Fund. But I think that expecting AI to save money immediately is optimistic.
And I'll add that at least, what we have said federally, we've supported other AI companies, and we also believe that we know that when you think of a solution like ours, it's the increase of documentation and billing. It's not quite capturing what we think is important, right? It's not capturing it's not capturing the risk. It's not capturing those social determinants of health. And if we can get payers like Medicare and others to kind of align on better outcomes and care coordination, then we can align the technology with the health outcome.
Interested in how this group is thinking about squaring the pace of innovation in AI with the pace of change in policy. I think we have the worst AI we're ever going to have right now, and we have no idea what's going to happen in 2 years and 5 years and 10 years and what's going to be available. So it's kind of setting aside the role of policy. I'm really curious about how this group is thinking about kind of policy implementation and policy development. Do we have the right people in the room? Maybe this is a question for Christina, but I'm really interested in everybody's thoughts and perspective. Thanks.
So I have two thoughts to kind of, one of which is, I think as a person who does policy in the digital health space, it is an amazing place to be doing policy because everyone's still trying to figure it out. There's an enormous amount of cooperation. People are all coming into the room. But it is challenging. And I think when we were thinking about, just to kind of throw out some supervised machine learning, kind of the machine learning before 2019, I think that there was some progress made there, and then generative AI sort of hit the scene. And so, it is complicated. I think the one space that we do need to remember is that these tools are coming quickly. Hospitals can only implement them so fast. They have to train their workforces. They have to set up the data. So there is I think that we can't just think about the pace of invention. We also have to think about the pace of deployment and whether there's some space there.
The one thing I'll add that I've personally enjoyed, having been in government a couple decades now, that I thought we did pretty well in California with the pace of AI change, is bringing in a broad spectrum. We've got industry at the table, we've got academia at the table, right? We've got different sectors at the table, and there's room to improve and still continue on that. But I think that model's been really helpful, that we haven't gone into our government cocoon and thought about policy like we sometimes do, but instead said, whoa, like this is a lot. Like, who's been working on this, right? Who didn't just realize that AI was a thing a couple of years ago, because people have known that for a decade, but we weren't doing policy.
Jared Fessler, Director of Communications and Programs for American Nurses Association, California. There's a lot of discussion around human in the loop, so the direct decision approval. How do you think this model might expand beyond that to human on the loop, sort of a supervisory oversight with an ability to intervene, and human over the loop, sort of governance level oversight over autonomous systems, and what policy recommendations would you foresee?
So I would say that those are actually different. I think that when we talk about human in the loop, that is a risk mitigation. You're putting a human into review. It's meant to be kind of an augmentative addition. I think when we're thinking about the supervisory, that's part of the overall solution, right? So in that case, there's a lot of autonomous AI. But the AI itself says, I'm actually not certain enough about this. I need to punch it up to my supervisor. So I think that there's a distinction there because you don't have the risk mitigation of every single review. You don't have the risk mitigation of a human saying, yes, that was a certain answer, no, that was not a certain answer. So I do think that there's an important nuanced distinction there. And I think in the end, I think that we need to think creatively about how to set up the right risk mitigations for the right situations.
The question is around accountability. If AI goes wrong, who is accountable? Is it the vendor who supplies the AI agent? Is it the health system, let's say Winters Healthcare, or is it the provider? Can you talk about who is ultimately accountable and where is that accountability documented?
That's a great question, and I think it depends on what you mean by what goes wrong with AI. In other words, if you talk about imaging for AI is a diagnosis that's happening right now for us. So that's a clinical decision that a camera is making versus, right? So who's responsible for that if the camera makes the wrong decision? I think what we've seen is, it's going to come back to us at some point for a misdiagnosis. It's going to come back this way, right? If we're using AI to misdiagnose, unless we know that the model was trained on this, it had some inherent bias, it didn't include enough Latino farm workers, and it couldn't pick this. If that's the case, that's great. Then we know we can go back. But that's not the case now in terms of things. We have BAA set up, in terms of organizations. Does that work well? I would say no. I think I've seen, so we operate an electronic health record, Ocean Epic. They have a third-party vendor that's a clearinghouse. We have a BAA with Epic if something happens to our data. What happened was the third-party vendor that was a clearinghouse had a data breach, internal data breach, all right? We didn't have an agreement with them. It was from another vendor, all right? And so, but we were ultimately responsible for notifying the patients. We had to get the lists. We had to go forward. We wanted to know the details. We couldn't even get the details because we didn't have an exclusive BAA with this particular vendor. So it's not clear to me all the time how that's going to happen, and I think that needs to be resolved as we move forward. I don't have a clear answer for you. But again, my experience right now is it's ultimately going to fall to me right now.
Hi, Stephanie Irwin here. Just a question for Christina, or maybe somebody else can answer as well. You mentioned states working together on governance and risk in regards to AI. I'm working on a project with Dr. Carey out of Duke on health equity and AI, and we are looking at a lot of frameworks, a lot of governance, and there seems to be a whole host, a plethora of different I wouldn't say standards, but what people think is best practices. Do you foresee us getting to a place where there is something that is federally or nationally accepted as guidelines like we do in accounting, like we have GAAP? Do you see us getting to that point? And if so, what does that timeline look like?
you're correct. There's a lot of people, there's a lot of groups, including myself, who are putting out a lot of literature right now, often about what I would term emerging practices. And I think the key is those standards groups that do exist are looking at all of those frameworks, and they're trying to bring them together. And we are seeing that there are standards around AI that have started to come out. I know that CTA has some. There's several other entities. So I think that we are seeing it. I think where it becomes challenging again is that you can have a standard that becomes obsolete when a brand new technology comes out. And so, I think that it makes it trickier than things like electrical standards. But I don't think just because it's tricky means it's not worth doing. It's just a continuous process.
What's striking to me about this conversation actually is that although there are open questions, that these challenges don't feel insurmountable, that we do have some early learnings on what good policy can look like. We have a provider that's deploying AI in a constrained environment and exploring some of those active questions that one of our audience members brought up. And so for me, I think the question isn't if and how AI will impact healthcare. It's here, but how policy can actually intentionally create the healthcare system that we all want to see. So thank you so much for sharing your perspective with us. And thank you all for attending our briefing.